Hey guys, my name is Miguel and I am one of the respiratory therapists here at St. Joe's. If you have if you have my clinic, then obviously you would know that. But again, I'm just making a brief video. Hopefully, it won't be too long, just to kind of give you guys some information that I thought would be helpful for you just on this first year and hopefully in the future as well. So again, this is going to be very brief information regarding CPAP and BIPAPs, and I have a little bit of paper here that's going to help me keep my thoughts and processes in the right order, I guess, just because, again, making a video and talking to a camera isn't quite the most easiest thing to do. But again, but this video right here is just going to be in regards to understanding a little bit more about CPAPs and BiPAPs. So in that case, we know that CPAPs and BiPAPs are non-invasive ventilation. It's, the way that we all often like to describe it is it's kind of like a lesser way for us to kind of provide support without actually having to intubate a patient. So obviously we know that intubation is the most drastic way, or is the most like invasive way to support breathing difficulties and things like that. So in this case scenario, we're just providing a non-invasive way of ventilation so that we can help our patients breathe better, right? So I know that there's usually a talk about BiPAP and CPAP and what is it exactly. When we see it on the floor, we typically see it for different type of situations and why we're supporting it. But for the most part, when we talk about continuous positive airway pressure, we often know that the reason why we do CPAP, right, continuous positive airway pressure, is mainly because at night when patients go to sleep, a lot of the muscles of the throat and then the muscles of the tongue just kind of relaxes. They relax throughout the night, and then what that tends to do is kind of just basically allows those muscles to kind of fall back in the airway, and then it would just simply just occludes the airway, right? So we have a brief understanding of how that can be just something that we don't want it to happen, right? So these type of patients that are going home and then they don't realize that they have sleep issues because they're just unaware of their health conditions. They tend, if they have obstructive sleep apnea, these muscles again on the throat and in the tongue just relaxes so much that it just tends to fall back in the back of your mouth, and then it just occludes those airways. And then you can only imagine, obviously, if there's an occlusion there and then there's no oxygen going through, and then that just means that a lot of your organs throughout the night are not receiving the proper oxygenation nor ventilation that you need. So then that creates multiple issues and multiple problems for us to kind of resolve. So again, that's the reason why, obviously, with patients, they do a sleep study to try to ensure that these patients are either, if they do qualify for a CPAP machine or a BiPAP machine, that they are getting the proper testing done in order to verify whether they do have it. But sometimes, like, if you really go through and then you see some of these patients sleeping in the hospital, oftentimes you don't even need a sleep study to kind of recognize that, hey, they're obstructing. How do we know that? Because sometimes you look to your left and you see the patient just snoring, and then eventually it's just like complete like blackout. There's no breaths, no respiration, there's nothing happening, and then eventually you'll see them come up like after, almost like if they just revive themselves after a few seconds sometimes of just having a complete stop of apnea. And then those type of things are kind of easy to recognize sometimes if you pay really close attention. So eventually you'll get to kind of see a little bit of that as well. So again, it's CPAP is again continuous positive airway pressure, and the way that we like to define, or I personally like to define CPAP and BiPAP is there's two different things that we need to discuss, right? Before we get into the details of what how CPAP and BiPAP work. Why do we use them? Why do we use CPAP and BiPAP, and what is the actual difference? Well, the way I sometimes like to think about it in my mind is that there are two different types of issues that we tend to deal with in respiratory failure, right? So there's one type of issue that we always talk about, and that is hypoxemia. And then the other type of issue is what we call hypercapnic, or hypercapnic respiratory failure. So when we put those two things aside, then we can kind of distinguish where essentially our problem is happening with our patients. So when it comes in terms to figuring out what we can do for our patients and how we can treat them better, we have to either set them up in these two different categories. And sometimes these two categories can go together, but it's just for the purpose of understanding. There are two different categories. One, either they are hypoxemic or they're hypocapnic, right? They're, not ventilating well, they're just not oxygenating well. So CPAP, for example, is just a really good machine in regards to just like being able to treat like the hypoxemia that we're talking about. So in that case scenario, what we're talking about is just much more about like how do we define that? So when you get a blood gas, right? If you absolutely have to do, and a blood gas is somewhat of an invasive procedure to do. You get an arterial stick, right? And then you're drawing some blood and you're running it through a machine, and then that machine is going to give you some results that eventually is going to help you determine whether this patient is hypercapnic or is hypoxemic, right? But let's just say that that you do happen to do that because you find a patient on the floor that is either struggling to breathe, their respirations are quite high, meaning anything over 30, and then you can see that they're using accessory muscles and all of those type of things are happening all at once, and you want to determine where this thing, where is the respiratory distress coming from. Well, if it is a hypoxemic issue, you're going to determine that and that PaO2 and the blood gas results, that you got, you're going to see a PaO2 anything less than 60. So obviously that's determining, depending on how much FiO2 you're delivering as well, it determines how bad your PaO2 is as well. So if you're delivering up to 100% and you have a PaO2 of 60, that's extremely critical, right? But just when you follow the oxygen desaturation curve, you can kind of tell whether how good or how bad that is. But again, when we get a blood gas, and let's just for a plain scenario, let's just say that your patient was in a couple liters, maybe 5 liters, and you get your blood gas, and then your PaO2 is somewhat 60s, and we know that there's obviously an oxygenation issue because our PaO2 should be much higher than that, just by the amount of oxygen that we're delivering. If that is the case, then we know that our CPAPs could possibly help with that. Now, we normally don't do that here in the hospital in the sense of rescue measures. Like, we don't just normally place patients on CPAP when they're severely hypoxemic or something like that, just because it's not the most adequate non-invasive ventilation machine to provide rescue. But for those type of patients that again have sleep apnea, and then they do have some sort of hypoxemia throughout the night, then it is very helpful to kind of provide that pressure support. So the type of things that we tend to do is, again, you can treat it, right? If we're trying to use type 1, right, hypoxemia, and how do we treat it? We normally want to either provide oxygen, and that we can do through the machines that we have as well. And then the other thing that we could do is, again, just increase that mean airway pressure. So how do we do that? Through the pressure support that the machine does. So CPAP, that continuous airway pressure, is a pressure that we utilize in order to kind of increase that mean airway pressure. So we'll go in details a little bit in regards to what that means, but let's move on a little bit to BIPAP. So BIPAP is a little bit essentially just CPAP on steroids. That's how I normally like to explain it to the students. So again, it's like one of those type of things that again it's what we call bi-level pressure, and that basically is one pressure above, one pressure below, and then this type of machine is more so for patients that are suffering from respiratory hypercapnia failure. So that means that they're not ventilating properly, and it could be both. You could utilize these machines for both issues, and that's why again it's CPAP on steroids, because even though the other one helps with certain things, then this one basically combines the effects of both to kind of aid the same situation. So if you have again hypoxemia and then you have hypercapnia, then this type of machine is obviously going to support you in both ways. So in order for us to kind of understand how to use these machines, we kind of have to just find out exactly what's really going on with our patient, why they're having a respiratory distress issue. So again, the most important thing about these two machines is understanding, one, what type of issues our patients are having, and if they are having, again, respiratory issues because of hypoxemia, then we can fix it by giving oxygenation and increasing our mean airway pressure. And if they're having issues because of hypercapnia, then we need to think about how we can possibly help them ventilate better. So that's the first thing that we need to understand about those type of machines and how do we use them. Now, in regards to explaining the basics and then the settings, I will try to do that just a little bit again, very brief. I just spent like 10 minutes just kind of going over that, so I'm trying my best here to kind of make it very simple. Um, Again, this machine right here is the BIPAP machine. I'm not exactly sure if we'll get enough time to kind of touch through all of that, but and then the one to my left here is the CPAP machine. I'll show you a little bit about that. But again, if we're talking about CPAP, we're again want to think about what type of patients we're treating. So CPAP machines, continuous airway, positive airway pressure machines, are more so for specific patients, such as obstructive sleep apnea patients. And then again, there are two different types of obstructive sleep apnea. The one is just, again, normal obstructive sleep apnea when the muscles relax of the back of your throat and then the tongue and all of that, and it occludes the airway, and then the patient can no longer breathe throughout the night. And then the next one that we have is central sleep apnea. So central sleep apnea is more so of the brain not being able to send the right signals down to the diaphragm and all of that throughout the night so that the patient can take breaths. If this is happening, then obviously it creates an issue because you're not going to breathe throughout the night, and it's a bigger problem. But either one of them can be fixed with our machines. So whether it is your obstructive sleep apnea or central sleep apnea, we can utilize one or the other to kind of treat this type of conditions. And then the other thing that we need to think about is what other effects or beneficial effects that the CPAP really have in patients. So one of the good things that we eventually you'll probably if you haven't yet realized this, is obviously, what we call CHF, cardiac heart failure patients. It becomes one of those type of things that it becomes very beneficial for those type of patients. And the reason why we say that is because CPAP, as being a pressure, it increases your intrathoracic pressure, and then that intrathoracic pressure decreases your preload. And when your preload is decreased, and we know that it has in terms of a side effect of just kind of, in this case scenario with CHFers, because that's kind of like what you're trying to do, decrease your preload, it will have an effect or opposite effect of increasing your cardiac output. Now, if that's the case, then we know that we're kind of helping out with this, the issue of what CHF is. You're kind of just helping the cardiac output move along. And the other good benefit of that is obviously that, like, if you're increasing those type of pressures, then it's allowing those recruitment of the alveolus, and if the alveolus are better recruited, then that means you're basically occupying more of those type of things, or you're at least freeing more of those alveolus that were atelectatic before, and now they're able to oxygenate better and then ventilate better, essentially, too, because there's more carbon dioxide that's being able to be exchanged if you obviously if you recruit a lot more of them. So the type of settings with the CPAP machine, when we talk about just regular CPAP, and then this is one right here. So this is a RespiMed. We have some of these here in the hospital. They also can be BiPAPs as well, but the RespiMeds are very good because they create, you can go in there and just maneuver a little bit of the settings, and then when we talk about settings, it's it could be very simple in regards to how we set it, but normally we just think of one pressure, right? So anything between like 5 to 25. Sometimes a lot of machines don't even go higher than 25, I believe. But why do we do 5 to 25? Well, in many books or just some of the studies that you may have found, there's a lot of things that we talk about this, like just anatomical PEEP that we have, right? So normally we have a normal anatomical PEEP of just like 0 to 3. Some people say 0 to 0 to 3, or 3 to 5, something like that. So we have some sort of anatomical PEEP, and I normally like to say that it's somewhere between 5, that keeps our lungs open. So in order for us to do that, we need to understand that when we put in patients in CPAP, that anatomical PEEP is being supported as well. So those type of pressures will be anything between 5 to 25. And if that's the case, then we know that the issues that we could have with this type of pressures is if you increase too much of that pressure, then kind of like that benefit we were talking about before with the CHF type of patients, is if you're increasing those pressures, and now you're increasing that intrathoracic pressure way too much, where it's causing now a lot of hemodynamic instability. And if that's the case, then we're essentially causing cardiac output to drop, and it's not essentially the most beneficial thing anymore. So we have to be very careful on how much pressure we do, and those pressures are being delivered in two different kinds of ways. One is either through the nose or through the mouth. So we utilize nasal pumps, or we utilize a nasal mask, or something that covers either one of those two areas, and then obviously the pressure goes in, and then you can bleed a little bit of oxygen through them as well. So again, those are the type of things. It's a very simple mode in regards to that. There are type of things that you can kind of manipulate, and hopefully we can I can get a little bit more in depth in that in regards to how do we fix those, how do we fix patients in those machines with the rise, the flow, and those type of things. But it would just take too much time to go over it in one video. I wanted to make it somewhat short. But again, and the other thing that you want to be careful with increasing pressure, other than just increasing your pressures and causing that intrathoracic pressure to increase, and is that if you're increasing too much pressure, then obviously a lot of that pressure is going into the stomach as well. And then if there's too much air in the stomach, then that could cause also like maybe vomiting and things like that. Obviously aspiration throughout the night. So we just got to be careful, especially a lot of these patients that may not be aware how this functions. They go home, they eat, and then they put themselves in the CPAP machines, and if their pressures are really high, acid reflux can happen, and those type of things could contribute to maybe aspiration, pneumonia, and things like that. So we just kind of have to be careful on how much pressure we give them, and only to give them the pressure necessary that they need. So if that makes sense, that's kind of like what continuous positive airway pressure does with basically CPAP. We utilize it to either help with oxygenation to a certain extent by just bleeding in oxygen, or we do it to just help with atelectatic stuff. We're trying to help those alveolus open. Obviously, it's been more beneficial, and we utilize it mainly for obstructive sleep apnea, whether it is central sleep apnea or just regular obstructive sleep apnea. And then one of the important things that people, that we need to understand is that the CPAP effect also helps our FRC, the functional residual capacity. So when you have a better functional residual capacity that our lungs necessarily need, then we have better breathing patterns. So that's with that. Obviously, the next machine is just our regular BIPAPs. So with our BIPAP machine, it's bi-level positive airway pressure, right? That's what that stands for. And this type of machine, we utilize it more so for hypercapnia patients, right? We think about it more like, again, our CPAP on steroids. It has two different patients, and then those patients that are unable to ventilate. So in this case scenario, we often say that this is like one of the best machines to prevent intubation. So when you're looking at a patient that may be severely sick, and then you feel like there's not a whole lot that you can do, this is one of the machines that we think about, because obviously we know that we can prevent intubation or an invasive way of ventilation by just utilizing this type of machines that just gives them a little bit of support through their issues. So when we're setting these type of pressures, we want to think about what kind of settings we should put these patients on. Well, we know that there's an IPAP and then there's an EPAP, right? So the IPAP is that amount of pressure that goes in the high. If you're looking at a V60 BiPAP machine, then there's the IPAP, which is the higher number, the higher pressure, and then your EPAP, which is your lower pressure. Now, the high pressures, depending on what book you read and anything related to that, and just think about it again, it's a pressure that you want to keep anything between 5 to 25, maybe 30. Obviously you wouldn't want to go anything higher than that. Even higher than 25 can be something, they're drastic pressures, right? But just think about setting wise, anything between 5 to 25/30, right? And then for your EPAP, essentially you could go almost the same thing too, but you always want to think about EPAP not being anything higher than your IPAP. And the reason why I say that is because, again, IPAP is the amount of pressure that gives up initially, and then EPAP is the amount of pressure that is sustaining back, so trying to maintain those lungs open. So when you combine those two pressures, and then the way to look at it sometimes is like the amount of pressures, you want to ensure that the pressures between the high and the low pressure is somewhat of a good distance to give what we call the ideal body weight tidal volume, right? So we determine ideal body weight tidal volume by looking at the height and weight of the patient. So if you're given an IPAP and then you're given an EPAP, but you're essentially decreasing those two things together by increasing one and then decreasing the other, then that means that separation or the middle of those type of things is a lot less than what you want it to be. And if that's the case, then you're essentially is what we call pressure support. So the pressure support of the patient is the differences between those two pressures. And if your pressure support is like 5, let's say, then your tidal volume is going to be like 100 or something like that, depending on what patient you're ventilating and depending on how sick their lungs are. So when you think about when you increase those type of pressures, you always want to ensure that you obviously are giving enough IPAP and EPAP to give your desired pressure support. So sometimes that's why I always tell my students, like, if you're going to go up in your EPAP and you don't want to lose a little bit of that pressure support, or you don't want to give too much pressure support, you want to make sure that you also go up on your EPAP, because otherwise you're gonna lose some pressure support. And if ventilation is your issue and that's what you're trying to achieve, then obviously you want to ensure that that your pressure support remains the same. Now, again, the benefit of BiPAP is obviously that you can oxygenate as well. So if we're talking about EPAP, in effect, obviously that extended pressure time that is being held when the patient is exhaling and just keeping those alveolus open just allows for so much better recruitment, and then obviously allowing the alveolus to just kind of pop open again. So that's just kind of like one way to think about it. And then the amount of pressure, again, is the tidal volume that you're delivering, and then just allowing the gas exchange to happen, and then obviously getting rid of CO2. A lot of students have asked me in the past, and they have a lot of just difficulty understanding the rates that we set on our CPAPs, or not CPAPs, sorry, BiPAPs. To understand the rate is it's more so of like when we set the I time and a rate on a BiPAP machine, it's not necessarily like the regular rate that we set in a ventilator machine, but the way it works is almost like it's like when you set those two settings, sorry, I can't even talk, but when you set those two settings, you're telling essentially the machine when to drop your IPAP to that EPAP. So what it means is that, like, that amount of time is when the machine is going to drop into that EPAP effect. So IPAP time and then drop to EPAP. So so it's not necessarily a rate, but it could essentially work something like similar to a rate, because you're telling the machine exactly when to drop from the high pressure to the low pressure. So I don't know if that makes any sense, but if you have any questions, you can always test me or something. But that's essentially what our respiratory rate and I time is. And then one of the obviously not these machines, but some of the machines like V60 would have AVAPs, which is average volume pressure support, and that setting of mode of ventilation is where we can kind of target certain things. So obviously, if you're thinking that you want a patient to just kind of like be able to blow more CO2, and then you want to ensure that their minute ventilation, which is essentially their tidal volume and respirations, are somewhere within a good range to ensure that this patient passes over the hump, then this is a great mode of ventilation for that. You are able to set up a tidal volume, a rate, and then you are able to set up two pressures basically, a minimum pressure and a maximum pressure. And then if that's the case, then the machine itself it has incorporated system where it's gonna manipulate those two pressures in order to achieve your tidal volume that you have set, and then obviously your rate drops in between that. But obviously when you set those two pressures, if if the patient for whatever reason is not taking enough big breaths, then the pressure will increase, and then your minimum pressure will also increase to kind of ensure that the tidal volume that you set will kind of be delivered. So that's kind of like a nice mode of ventilation, again, to utilize that's not invasive, but it's not invasive when you're trying to help patients with hypercapnia. So again, that was kind of like, gosh, it's 24 minutes. I thought that this would be a little shorter, but obviously it wasn't. So again, hopefully that kind of gave you a little bit of understanding of what those two type of what CPAP does and BiPAP does and how they function. And this right here, I'll just show you a little bit in regards to what it looks like. And then at our hospital we have them label, but you know, I'm not going to turn them on yet because that will be for another video. Hopefully we can go in depth a little bit about that. But here's our BiPAP machine, and they can also come on a CPAP machine, and then maybe we can get in depth later in regards to how, you know, how you can set them up and function them. Hopefully this video was helpful to you. Let me know if it wasn't, and if it was, I'm glad it did. Again, if you have any questions, just please feel free to contact me, or just text me or email me, whatever you guys want. Thanks, and have a good day.